Good morning, dear student. So today let us discuss the second case from the neurology. Okay. Earlier we had discussed one case from neurology, and let us discuss the second case. The history for this case was written by Dr. Sam Dodari, who had just passed his MD internal medicine. So I am just going to read out his history and try to explain the history. So here is 80 years old male from Dharan 3 Sunsari, shopkeeper, Muslim by religion, literate gentleman, who admitted in the medicine ward around 3 days back. The informant was the patient himself and his son, and it was adequate and reliable. The presenting complaints of my patient were weakness of bilateral lower limbs and tingling sensation of left lower limb for 2 months. So there is presenting complaints. There are two presenting complaints. There is weakness of bilateral lower limb for 2 months and the tingling sensation of left lower limb for 2 months. So when we get such presenting complaint, system wise we have to think about the nervous system, because both the symptoms are related to the nervous system, weakness and the tingling sensation. As we know, the nervous system basically has the motor component, sensory component and the autonomic component, and the weakness is especially the motor component, and the tingling is the sensory component. So this patient has the involvement of the motor component, motor pathway as well as the sensory pathway. So weakness here. So in a neurology we have to know the exact meaning of weakness. So weakness means it's a decrease in the power of the muscle is the weakness. If I can leave this paper or copy as a notebook, this is my ability to lift this notebook. But if the persons of my age and my gender, if they could not lift this notebook, then probably that may be because of the reduction in the muscle power. So power is basically reduction in the power, and the other terminologies that are close to the weakness are fatiguibility and asthenia. Fatiguibility is inability to sustain the performance. Okay, sustain the performance. I can leave this notebook, but if I cannot sustain this for the long time, there is inability to sustain the performance. That's called the fatiguibility. And another one is asthenia. Asthenia means not performing the activities due to lack of desire. I don't want to leave this notebook. That's why I am not lifting this notebook. So it is not weakness or it is not fatiguibility, it is asthenia, because I do not have desire to lift this notebook. So basically here is weakness, and weakness is the motor component. So to understand about the weakness, so the cause for the weakness, we have to know the motor pathway. The main motor pathway is corticospinal tract, cortex to the spinal cord. In the cortex, especially from the precentral gyrus in the frontal lobe, there is area called area number 4, Brodmann's area number 4, 5 and 6. These are the motor area. 4 is primary motor area, 5 is premotor area, and 6 is supplementary motor area. From there, like fibers comes, they form the coronal digita, then internal capsule, then it comes along with the pons and then medulla oblongata. At the level of medulla oblongata, 80% of the fibers cross to the opposite side, mean that the fibers coming from the right side will cross to the left side and will like supply the left side of my body. At the level of the spinal cord, it runs along the white matter, and then another fiber will go and synapses with the cells of the anterior horn of the spinal cord. So till the anterior horn of the spinal cord is the upper motor neuron, and from the anterior horn and distal, from anterior horn they start the roots, and then ultimately it makes plexus, and then the nerve, and then neuromuscular junction, and the muscles. These are like make the lower motor neurons. So the anterior horn cell is the junction between the upper motor neuron and the lower motor neuron. So this patient may have involvement of this motor pathway from brain to the up to the level of muscle. We do not know that. By only listening the presenting complaint, this patient may have the problem in the level of the muscles, myopathy. This person may have a problem at the level of neuromuscular junction. This person may have level of peripheral nerve or spinal cord or brain stem or internal capsule or coronal digita or cortex. We do not know. Only by listening the complaint of the weakness of the bilateral lower limb, we have to dissect these symptoms. Okay, but these are the details. But the second symptom is tingling. There is sensory component there. Tingling is important here, and the sensory component, if there is a problem of the sensory components, then definitely there can't be a problem there at the level of muscles, because the sensory modality is carried by the nerves. So we can rule out probably this is not a problem of muscles and the neuromuscular junctions like myasthenia gravis, because there is sensory component. If there is a problem in the sensory component, then the problem may arise from the peripheral nerve or roots or spinal cord or brain stem or the cortex. Okay, but it's not at the level of muscles and the neuromuscular junction, because involvement of muscle and neuromuscular junctions do not cause the sensory symptoms. Okay, so this patient probably have involvement of the peripheral nerve or roots or spinal cord or brain stem, internal capsule or coronary or cortex. Okay, only by listening this to complaint. So let us listen the history of presenting illness. The patient was in his state of health till 2 months ago, when he developed weakness of bilateral lower limbs. It was gradual in onset and persistent. Initially, patient had noticed weakness of left lower limb more than the right lower limb, as he was walking on the ground. He could not bear his weight on the left lower limb, and he fell down on the ground, and on attempting on walking, the lower limb was flabby than before. However, he could walk with support of other person or with support of sticks. So mean that the patient had weak history of weakness, which started from the left lower limb, then it goes to the right lower limb, and patient need the support to walk. Okay, and there is like another important one clue here. According to the history, the patient had the flabby muscles, loosening of the muscles. Okay, and when there is a flabby muscles, then usually it suggests the lower motor neuron type of weakness, because in case of upper motor neuron type of weakness, if there is involvement of spinal cord or brain stem or above, then that called the upper motor neuron lesion involvement. That cause the hypertonia, not hypotonia. Hypotonia cause spasticity, hypotonia cause flabby. So as this patient has the flabby muscles, probably this person may have involvement of like it's a lower motor weakness. Lower motor means anterior horn, like distal to the anterior horn. It may be the problem of roots or peripheral nerve okay, or only listening to the motor from NMJ junction or muscle myopathies. But as the patient do not have the history of, patient has the history of the sensory complaint, it may not be the myopathy and NMJ junction. Probably the problems lies at the level of peripheral nerve. He also noticed he had difficulty in standing from sitting position and from squatting position, mean that he had proximal weakness. Proximal weakness of the lower limb presented with the difficulty in standing from the squatting position. That is the history that we are supposed to take. And he had also the history of slippage of slippers from left foot. Like when patient gave the history of slippage of slippers, then it suggests the distal weakness. So our patient had weakness in proximal muscle, especially by the muscles of thigh and the muscle of foot as well. Okay. He also described that he has sensation of the walking on the cotton on his left foot when he walk on the ground. There is no history. And in this 2-month period, patient had noticed that the bulk of his left thigh has become smaller. Like before going ahead, like he had taken the history of the patient had history of walking on the cotton, light sensation. So in the peripheral nerve, in the sensory modalities, patient can have small fiber involvement and the large fiber involvement. Small fiber involvement means there can be the pain. There can be the pain sensation, because pain and temperature is carried by small fibers. Someone has the pain sensation, burning sensation, a numbness, then it usually suggests the small fiber involvement. When there is a large fiber involvement, large fiber is basically for vibration and position sensation. When the large fiber involvement, then they cannot detect the position sensation, and they will they gave the history of the walking on the cotton or plaster cast sensation in the foot. So I think our patient is giving the history that he is having the involvement of the large fiber type of peripheral nerves because of history of walking on the cotton. Yeah. In this 2 months period, our patient also noticed that the bulk of the left thigh has become smaller as compared to the right thigh. However, there is no history of flickering movement in his lower limbs. There is no history of to and fro flickering movement of his ankle on climbing up a stair, and there is no history of stiffness of the lower limb. So there is decrease in the bulk of the muscles. It's suggesting that there is atrophy of the muscles, and when there is atrophy of the muscle, it usually suggests the lower motor neuron type of weakness. Okay, and he is also telling that there is no flickering of movement, mean that he is trying to so that there is no fasciculations and there is no clonus type of movement, and presence of clonus usually suggests the upper motor neuron type of lesion. So there are clues like when there is atrophy, then probably this patient has the lower motor neuron type of weakness, and the okay. Patient also gives the history of tingling sensation of his left lower limb 2 months back. It was gradual in onset and persistent. He described that the tingling sensation was around the left thigh, left calf, left sole. However, there was no history of pain in his lower limb. There is no history of burning sensation, numbness. So there is only tingling sensation, usually it's suggesting of large fiber type involvement. There is no history of weakness of upper limb, and there is no history of tingling sensation, numbness and pain in the upper limb. Upper limb is absolutely alright in this patient. No history of difficulty in left hand or above the head and combing and buttoning and unbuttoning of the shirt. So to elicit whether there is involvement of the distal muscle involvement of the upper limb hand, then we have to ask this tree regarding the buttoning and unbuttoning of the shirt. If someone has a problem in buttoning and unbuttoning of shirt, if someone has problem in writing, then it usually says that distal muscle involvement of the upper limb, and lifting the hand above the head or combing the hair usually says the proximal muscle involvement, proximal muscle. Okay. There is no history of girdle-like sensation on his body. There is no history of waning and walking of the symptoms, or history of worsening of the symptoms during night or darkness. There is no history of trauma prior to the illness, no history of fever, vaccination prior to the illness. Goiter-like, so if someone has the goiter-like sensation, then it usually suggests the myelopathy, usually in extra like duration compression myelopathy. Like there's someone has compression myelopathy, they can give the goiter-like sensation, but our patient do not have that history. Okay, and like waxing and waning of the symptoms usually suggests the multiple sclerosis is one of the common phenomena of the multiple sclerosis. If there is a waxing and waning of the symptoms, like relapse, the patient with multiple sclerosis has frequent relapse and remission. There is no history of lightheadedness and standing from sitting position, no history of heat intolerance, absence of sweating, and no history of postprandial blotting and bowel disturbances. Why he had asked this question? Can you guess that? There is no history of lightheadedness. He had asked this history to look for the autonomic symptoms, because when we are dealing with the peripheral nerves, then we have dealt with the like motor component, sensory component. Then we have to also ask regarding the autonomic nerve involvement. Like these are like someone has lightheadedness. These are the feature of autonomic failure. Absence of sweating is the feature of autonomic failure. Postprandial blotting is feature of autonomic failure. And because like peripheral nerve, there are so many peripheral neuropathies which may be associated with autonomic neuropathies, like in case of diabetes neuropathy, or Guillain-Barré syndrome, and sometimes in amyloidosis they can have autonomic component as well. There is no history of double vision, no history of loss of face, no history of loss of sensation of face, no history of difficulty in swallowing, regurgitation of feeds, nasal intonations, like that. Okay, basically like he is taking the history to check whether there is cranial nerve involvement or not, and from olfactory to the hypoglossal we have to take the history. Like for olfactory there is no history of like loss of smell, and for optic there is no blurring of vision. Then 3, 4, 4 like 3, 4, 6 for the like deviation of the eyeball. For 5 like trigeminal nerve there is abnormal sensation of face or mastication problem. 7 facial nerve like facial deviation. 8 the vestibulocochlear, then hearing loss or tinnitus. 9, 10th and 11 for gag reflex like swallowing difficulty, and 11 for the tongue deviation. You have to take this negative history whether there is involvement or not, because like in so many peripheral neuropathies there can be concomitant cranial nerve neuropathies as well. Okay, so you have to take the history. So these are the history of the patient, and the patient in the significant past history is like patient had the history of diabetes and was taking the medications, and hypertension and was taking the medications. There is no history of head injury and back trauma, and personal drug history, socioeconomic history, and family history does not seem like significant in this patient. So if you get like this type of history, then so how you proceed? So it's a very nice history here taken. So basically when you got this type of history, then as we have approached, like we have to, when you get these two presenting component, motor like weakness and the tingling sensation, this motor weakness can be occur because of UMN or LMN. Then so we are thinking the LMN involvement in this patient, because there is atrophy of the muscle, because the muscle is flabby, there is no clonus. These all are like suggesting that this patient lower motor neuron weakness. So lower at what level? Like it may be at the level of peripheral nerve, neuromuscular junction, myopathies, or anterior console. So if it is a case of myopathy, then myopathy usually present with the proximal muscle weakness, but this patient has problem in both proximal as well as distal muscle weakness. 1. Second is presence of sensory symptoms like tingling sensation usually rule out the myopathy. So we don't think that this patient has the myopathy. Why not neuromuscular junction? Neuromuscular junction will have only motor component, and especially they present from the muscles of the eyelid. Like most of the patient will have history of the ptosis and diplopia like that, but our patient do not have that symptoms. Another feature of my neuromuscular junction is the deterioration of the motor weakness with the day, as the day passes, but this patient has persistent weakness. So this rule out the NMJ junction disorder. So probably it is fitting in the peripheral neuropathies, peripheral neuropathies, and because there is also the sensory component, and the sensory component is usually suggesting a large fiber involvement. So probably this is a patient with peripheral neuropathies and predominantly large fiber type peripheral neuropathies. And common cause for this large type of peripheral neuropathy is like vitamin B12 deficiency, sometimes in case of diabetes mellitus, and sometimes in case of CIDP. Okay, CIDP, but the duration is not only 2 months. CIDP, these are the possibilities in this patient. There are other possibilities as well. So this is how we approach like this type of patients. So if you have any comment, then you can write in a comment section. Okay, thank you.